Welcome back. And we have 2 more hours of phenomenal lectures. I'm very excited. And here we go with Dr. Palathra, palliative care for pulmonary disease, another foundational topic.
So thank you again to both Monica and Ben for organizing this. I really want to thank all the fellows for being here and present. And I'll try to make this as interactive as possible, as much as I can through the internet. But a little bit about me. My name is Brigit Palathra. I'm the program director here at New York Presbyterian Queens. We're a relatively small fellowship. We started with 2, and then we've just recently gone up to 3 a couple of years ago. I was actually I was from the 2nd class, and I stayed on as an attending, and I stayed on as a PD, and I've taken on the role of PD last year. But before that, I actually worked for 10 years as a hospitalist. And I worked at a critical access hospital in a rural setting. So I had to do a lot of my own disease-directed therapy without specialists. And pulmonary was definitely one of these things that I came across. And what I failed to recognize as a hospitalist is really the key pivotal role palliative care can play. So I'm hoping that I can give you guys a broad understanding. It's in no way going to be completely inclusive. There's just so much details, and we'll be just focusing purely more on non-malignant conditions and not talking about lung cancers. I'm going to reserve that for our future lecturer. So we'll go ahead and begin. I have no disclosures. Just something that I wanted to add from our institution. We usually put up CLARE slides. So CLARE is the clinical learning environment review, which encompasses 6 fields, including healthcare quality, patient safety, teaming, in addition to 3 other fields. And what we like to do at our institution is really talk about, like, whenever we have educational activities, what these educational activities also align with regarding the clinical learning environment that ACGME promotes. So today's learning objectives, we're going to define the role of palliative care in advanced lung diseases. We're going to review some pulmonary specific diseases palliative specialists encounter. And I can't, without good conscience, have a discussion about dyspnea, since it's such a pivotal symptom and distressing symptom. Actually, it's more of a syndrome, like as you see, as we will talk a little bit deeper into it, in patients with respiratory illness. So we'll end out the lecture talking a little bit about dyspnea. So a little bit of background. So the foundations of palliative care evolved from, like, as you know, from many of the lectures you've had and all of your attendings have been talking to, origins came in hospice care, specifically in cancer care and end-stage disease. Now, what's happened within the last 10 years is that it's expanded to include a lot more chronic illnesses, including pulmonary disease. And as we all know, the ultimate goal of palliative care is to improve quality of life for patients and families. So it's from the time of diagnosis, which often encompasses a lot of the ideals of primary palliative care, throughout the disease trajectory, where there could be an overlap between primary palliative care and specialty palliative care, which is what we all train to be, and end of life, specifically patients that are dying or patients that might be going into hospice. It still remains an unmet need for many patients, especially those with respiratory illness. And there's a profound impact of lung diseases on patients' function and quality of life. So the management, as you know, in a lot of our diseases requires a lot of complex interdisciplinary teamwork and encompasses multiple domains. Just out of curiosity, that last statement I talked about domains, is anyone familiar with the NCP guidelines and the domains, the practice guidelines for the quality of palliative care? Has anyone ever come across that? You can shake no, you can shake yes, whatever, not sure, that's okay too. I'm not going to delve into too many details about that, but you can access this actually readily from the website. Oh, let me go back, I overshot there. And these clinical practice guidelines are actually on their 4th edition. And the intention behind it is really to design a structured way of approaching how palliative care should be delivered, not just at the patient level, but, at a systems level and a national level. And it encompasses 8 domains, which really overlap a lot of the things we do in palliative care, right? The structure and process of care, the physical aspects of care, psychological and psychiatric aspects of care, social aspects, spiritual, cultural, care at the end of life, and ethical and legal aspects. And the reason why I bring it up is because the second part of my lecture will be about disease-specific things, but it's not really going to talk about, it may not always bring up these different domains, but I want you to always keep in mind whenever you're approaching a patient, whether it's a patient with pulmonary disease or any sort of life-limiting disease, this is actually the way you should be constructing and thinking about how you're approaching care. And if you're looking to the future, especially the submissions are going to be coming in for AHPM later this year. One of the first things they're going to ask you when you submit for your case study or your eScholar poster is like, what are the domains that you're planning to discuss and incorporate into your presentation? So I highly encourage you to read up a little bit more on this. So in regards to structures and processes of care, I think the important thing we have to recognize in pulmonary disease is that prognostication can be very difficult, especially in the non-cancer lung disease. The trajectory is unpredictable, and it's prolonged with intermittent life-threatening exacerbations. And we'll talk a little bit more about that. And then that question about primary palliative, what are the pulmonologist's responsibilities? What about the other co-managing physician responsibilities? We know what our responsibilities are, but are they really well defined? And I think, this highlights, I think everyone's familiar with this disease trajectory, and this actually represents a lot about non-cancerous pulmonary disease and what often happens to our patients. What we see is, patients have this progressive slow decline in functional status, where they, at the time of diagnosis, and they'll have an exacerbation that will lower their functionality, make them more ill. They'll come back, but they'll not quite come back to where they were. And this is the continued process that happens until the time of death, which really makes it really difficult to say, okay, is this person at end of life or not? The next aspect that often comes up in managing patients with pulmonary care is the physical aspects. Dyspnea in itself is a major symptom, but you also have to keep in mind there are a lot of other co-symptoms that work in tandem and really impact quality of life, and cough is one of them. Other symptoms we do tend to address sometimes, rarely hemoptysis, often we do address secretions depending on the disease. But the things we don't always think about are the non-respiratory conditions that often accompany these patients, because they often have a lot of comorbid conditions like pain, fatigue, as well as cachexia with long-standing disease. I think one way to take a look at it is recognizing a lot of times what happens in patients is that there's often an overlap, and there's overlapping conditions. And these all contribute to different reasons why someone has dyspnea. I mean, you have cancer-specific issues that might relate to dyspnea. You may have non-cancer specific issues that might relate to dyspnea. And then you'll have overlapping things that you'll see in both realms, which makes the care really complex. And another thing to keep in mind is these patients endure a lot of psychological and psychiatric aspects of care due to the degree of illness that they have, the disease burden, the symptom burden, and the long trajectory they often endure. These patients have adjustment disorders. They have a lot of anxiety and depression because there's a lot of prognostic uncertainty about what's happening to them. They have difficulty sleeping at night. On top of that, often they have concurrent illnesses, non-pulmonary conditions that add to the symptom burden and suffering. Another thing to also keep in mind with these patients is that there are a lot of social aspects that we don't necessarily always address in medicine. And I think it's something we have to keep a beginner's mind and open lens with, because if we don't, we sort of let our own biases come in and we don't recognize sometimes what our patients are enduring. There's sometimes a lot of social biases and stigma associated with some pulmonary diseases, such as COPD and smoking related issues. These conditions actually impact the patient's relationships with other people, their ability to have intimacy with their partners and other family members. It also affects their ability to earn a living wage and to work. The caregiver and the family often have their own burden, because these caregivers are not only managing these chronic illnesses for the patient, but they themselves also have their own illnesses, and they're chronically ill too. And these patients tend to be socially isolated. Does anyone have any idea what I mean by that, socially isolated? You could text it into the chat box if you want.
Like they feel like there's no one around them that have similar symptoms or going through the same disease process. So they feel isolated, even though they may have family members or friends around. No one's actually in their shoes.
Yes. What else?
Is it that? Is it another one? Is that like there's this like people look at them differently, or there's a disdain for the amount of smoking they've done to get to where they're like, you bust the smoking up to get to this point in life, and that's why you're here now. So there's a negative connotation to it.
Yeah, I mean, they have dependence. A lot of them still have an ongoing dependence with nicotine. And that is often used as a disparaging thought sometimes amongst their peers and providers. You know, a lot of these patients, when they're in advance, they're on oxygen. How easy is it to get out of your house with oxygen? Even if you have that portable mini thing, it's hard, right? To get around your house with oxygen, that's hard. And you're debilitated. You're often needing assistive devices to get into something, to move around, to get to the grocery store, to go to family events. You know, and I'm just going to share a dirty little secret with you guys. A lot of our patients with advanced pulmonary disease also have cough. And what happens with cough chronically? There's incontinence with cough. You know, you're not able to hold conversations. You're not able to hold your breath. It makes the dyspnea worse. So a lot of patients tend to stay home because of those types of things. And I think, you know, some other things to really think about is that, you know, pulmonary diseases tend to be more prevalent in populations with decreased access to healthcare. There's increased environmental exposures in these populations, in the poorer populations contributing to disease. It's also an older aging population. And the caregiver demands are really high. You know, the caregivers have to do a lot of multiple respiratory treatments, medications, pick up medications to pharmacy, maintaining oxygen. They often have to engage multiple specialists that are involved in the care, and it overcomes them and becomes their life, actually, managing their loved one. And, you know, and these other aspects, spiritual, religious, existential, cultural, you know, when you're near end of life, these are all things that really inform our patients, their family values, their beliefs and healthcare decisions. So I think that's something we really have to take into account. A lot of these patients, the majority of them are facing their own mortality. And that is interpreted and informed in different ways based on your upbringing and where you are. And I think when we talk about that, I think when we're caring for these patients and family, humility is key. You know, I've been suspect in that, of being judgmental, and I'm learning more as I go into medicine, especially in palliative care. I have to have a beginner's lens and be open and listen to the story, because every story is different. And you have to recognize that you understand far less of what the patient and caregiver lived experiences are. So that's a critical and important point to listening at the start of when we're doing a consultation and providing support. Some signs near end of life, that end of life discussions are needed, and this is adapted from Curtis. And you know, I'll be happy to share all these slides so we can go over it. But you know, these are some ideas and thoughts about, you know, increasing dependence, functional status, weight loss, concurrent heart failure, admissions, oxygen dependence, and a very low FEV1, less than 30%. And
Hey,
then
Dr. Palathra, there's like a screen, a square in the middle of your screen that.
Oh, I think someone's trying to. I was opening up the chat box. Sorry about that.
Okay, thank you.
I should move that over to the other side so I can see it. I'm going to move that now. Thank you for pointing that out. Then there's the ethical and legal aspects of care. So I think, you know, Dr. Gunderson spoke to it a little bit, but, you know, there's a lot of overlapping things that get encompassed in palliative care for pulmonary disease. There's the ongoing advanced care planning and goals of care discussion as the disease progresses. There's discussions about code status. Also that often comes into play is talking about palliative extubations, which we often get involved in, and liberations for advanced technologies. Some of these patients go on for lung transplant. Some of them have gone on for lung transplant and they're developing rejection. And then there's always those questions that may come about at end of life about palliative sedation and medical aid in dying or physician-assisted death. So, it's important to remember like how critical a role we play and how complicated of a role we play. So let's talk a little bit more about disease-specific states. So just to talk about the major disease that we often encounter, COPD, what we know about it, it affects a large number of Americans, 16 million with the latest count. It's the fourth leading cause of death. And as we know, it's an airway disease as well as a parenchymal disease. And there are often chronic respiratory symptoms like dyspnea, cough, chest tightness, and weakness. Airflow obstruction and spirometry is required for diagnosis if you ask your pulmonary colleagues. These patients tend to have recurrent hospitalizations and intensive care unit admissions toward the end of life, and this contributes to patient and healthcare costs. And like we mentioned before, prognostication is very difficult. There's a variable heterogeneous disease trajectory, and there's an inaccurate ability to predict the end of life. We just don't have any great models that can tell us exactly when someone's going to die. We can have some ideas about all-cause mortality, maybe even 2-year mortality. Bode index is one we tend to use, which often includes a lot of physical aspects as well as multiple domain aspects, including the MMRSC dyspnea scale. It includes a 6-minute walk distance as well as the FEV and BMI. These tools honestly probably don't tell us really great about what immediate mortality is, but probably a worsening Bode index, what it may tell us is that as the index gets worse, that who is need for specialty care. There are some universal factors that are associated with more than 50% 6-month mortality. Poor performance status, advanced age, malnutrition, comorbidities, organ dysfunction, and hospitalizations for acute decompensation. The other thing to keep in mind is COPD often overlaps with other medical conditions. So it's often recognized that there's a systemic inflammatory aspect to it, not just from the illness itself, but from all the other comorbidities that it has, and it contributes to the mortality. Often these patients have issues with metabolic syndrome, hormonal imbalance, hypoxia, weight loss, all contribute to this, as well as ongoing skeletal muscle loss and weakness with limb muscle dysfunction, and they have concurrent anxiety and depression. These patients tend not to just have COPD. How many of you guys have ever just admitted a pure COPD patient during your initial training? I'd love to meet you guys because I have not done that in 5 years. I've only seen patients that have something concurrent, whether it's hypertension, CAD. These patients also have some sort of gastroesophageal dysfunction, often develop microaspiration. They often have osteoporosis, likely related a lot to advanced age and chronic steroid use. And the other thing too is COPD is sometimes not on its own and solitary. Sometimes there's some overlap with other conditions like bronchiectasis, interstitial lung disease, lung cancer, obstructive sleep apnea. And all of these things are associated with increased symptom burdens, and they all negatively, collaboratively negatively affect the clinical outcomes. An important thing to remember about these COPD exacerbations is they usually, like we know, they're where the patient is having an acute abrupt change in their dyspnea with increased cough. There's a change in the sputum. This is often triggered from an infection or some sort of environmental process. What we know about these exacerbations is that there's an increase in the symptom burden. They may have a temporary decreased lung function at that time. It does, with each exacerbation, it contributes to poorer health status and quality of life. With each one, it increases hospitalization and risk of hospital readmission. And as they occur more frequently, there's higher risk of COPD progression and mortality. And the truth is, knowing all of this and knowing that we've been in palliative for so long, what we do know is that the symptoms and burdens are under-evaluated and poorly addressed when you compare them to, let's say, lung cancer, which has been more extensively studied. Patients, even though they may have inhaled bronchodilator therapy, they've done surveys on patients and they still have very high symptom burden, specifically dyspnea. And it's not really systematically or effectively addressed. Our COPD patients also have greater symptom issues, including breathlessness, anxiety, and lower rates of complete dyspnea relief during the last week of life compared to the concurrent cancer patients. and symptom relief prescribing, meaning prescribing of opiates and other medications that might aid in symptom relief at the end of life, is less in COPD patients compared to cancer patients. So just keep in mind, there is specific hospice criteria, and this is just a quick overview of it. And this is predominantly designed for COPD, but it overlaps with a lot of other concurrent pulmonary issues. And in addition to having a less than 6-month mortality, what you also need to have is a severe chronic disease that is showing some form of disabling dyspnea, with also a progressive increase of going back and forth for hospital visits or increased physician home visits. You may have a measured FEV reduction as well, but it's not a requirement. And having some concurring evidence like the hypoxemia on rest, being on supplemental oxygen, hypercapnia, or evidence of right heart failure due to pulmonary disease. So let's talk about interstitial lung disease. Interstitial lung disease is one of the more not so frequent diagnoses that you come across, but it is something that we do see. And it's a very broad, generalizable term, and it involves a lot of different conditions. So it's a very heterogeneous group, but essentially at the core of it, what we do find in ILD is that there's an expansion of the interstitial compartment of the lung due to fibrosis, inflammation, or both. And it's broken up into 4 major groups. The first one is idiopathic interstitial pneumonias, which is most commonly finding that we often see in our patients is idiopathic pulmonary fibrosis. Then you have the group that's caused by secondary causes like connective tissue disorders, exposures like asbestos, medication-induced, which we sometimes see in our cancer patients, chronic hypersensitivity pneumonitis. Less frequently, you'll see are diseases related to granulomatous disorders like sarcoidosis, and there's some rare conditions that do often pop up. But what you'll often encounter is IPF and some of the secondary causes, especially the drug-induced. The most common symptoms are cough and dyspnea and fatigue. And again, this is where we struggle. We don't have a predictable disease trajectory. And the treatment usually includes addressing the underlying cause if it's not idiopathic. So that includes like exposure mitigation. It also involves immunosuppressive therapy, corticosteroids, in some conditions, steroid-sparing agents. Historically, these patients had a median life expectancy of 3 to 5 years from the time of diagnosis, but a lot has changed in the last few years as a few more drugs have come to market. Specifically antifibrotic agents, which have been really changing how patients specifically with fibrotic ILD progress with their disease. These 2 specific ones, I hope I don't butcher the names. I'm never good at saying these. So it's nintedanib and pirfenidone, and please don't hold that against me. These are primarily approved for IPF, and what they are associated is reducing the rate of lung function decline. Patients may actually survive longer with these medications. They also may be at lower risk for acute exacerbations. IPF and ILD patients are very high risk for exacerbations, which land them in the hospital. They often need pulse steroids and supportive treatments. And what we do know is each time an IPF or an ILD patient does get hospitalized, it does impact increasing morbidity and mortality. These therapies don't stop the decline or restore lung function, they just prevent progression sooner than later. And it's not associated with decreased pulmonary symptoms or improved health-related quality of life. And they've just recently approved it for some of the non-IPF ILDs. So you'll likely be seeing this a lot more. And like I mentioned before, with ILD, because of the uncertainty, because of the severe disease burden, because of how disabling it can be, a multidisciplinary approach is needed because it is a progressive disease and there's a high burden and reduced quality of life. The side effects of medications may add to the symptom burden and compound and develop into frailty in a lot of these patients. And they also have overlapping comorbidities like cardiac disease and pulmonary hypertension, et cetera, which impact quality and quantity of life. And a thing to keep in mind, once they go on oxygen therapy, the mean survival is 8.4 months, which may be an indication for a specialty palliative care to be involved. Now, pulmonary hypertension. Pulmonary hypertension, it's a disease that's characterized by progressive increase in pulmonary vasculature resistance, and it results in impending right ventricular failure. So median survival has changed a lot in the last decade with the new onset of different various prostaglandin treatments. Without treatment, it's averaged about 3 years. With treatment, it could be 7 years or more. The clinical course is highly variable again. And again, this is what the frustrations are for us in pulmonary disease. We just can't have a good guess of when it's going to happen, but we have an idea of how things are getting worse. And it could all be due to the type, the functional class, and the comorbidities. So one of the things I recommend with not just pulmonary hypertension, but any of the pulmonary disease, specifically pulmonary hypertension, the ILDs, which are things we don't frequently encounter, is always engaging with the specialists and getting their input on the case. Because whatever, it's important that we're collaborating and we're coming from the same page, because we can get a better understanding from their perspective what treatment options are available and what's feasible, and what the patient's actually been enduring. So we know that there are multiple targeted therapies available that can improve dyspnea, exercise capacity, functional class, and healthcare related quality of life. But different populations respond differently to treatment. And I'm not going to go into too much detail because I can go on a whole lecture just on the treatment of pulmonary hypertension. But what you do need to know is that there is a WHO classification, and it's broken up into 5 groups. The first group is group 1, which is pulmonary arterial hypertension. It's often rare. It affects about 5 to 15 persons per 1 million. It tends to affect younger and females. There's better treatment options now, so these patients are not getting admitted as much and they're not dying as quickly. With treatment though, there is still a high mortality. There's a 5-year survival is about 65%. Poor prognosis is usually associated with older age, over 50, male sex, when they're not responding to the vasodilator therapy, and with the onset of right ventricular failure. Group 2, which is pulmonary hypertension that's secondary to chronic lung disease, has a more poor prognosis, and the 5-year survival is about 38%. Group 3 is the pulmonary hypertension that's related to our cardiac patients. And they have a very similar life expectancy as those with PAH or type 1. And then the other 2 groups that you do sometimes see includes pulmonary artery obstruction, so like our chronic thromboembolism patients, as well as with unclear causes. So I think the important thing to remember about what happens with our patients with pulmonary hypertension is what is physiologically happening, right? So this illustration was actually taken from an article. And what it shows is what's happening is essentially there's the increase in the pulmonary vascular resistance, right? So there's a increased vascular load on the right ventricle. So the right ventricle tries to adapt. So it increases and it tries to pump and it becomes thick and it's like building its muscles. And then to maintain the cardiac output, it actually also dilates, and then the heart rate starts to increase. And this increase in the wall and the oxygen consumption causes everything to dilate out toward the left side. And then what winds up happening is that you have this high metabolic demand and reduced output, which really affects the patient symptomatically and systematically. The common symptoms are dyspnea, fatigue, and exercise limitations. Group 2 or 3 also present with symptoms of chronic lung or cardiovascular disease. The progression marked by right heart failure is usually presents with these things due to the increased metabolic demand and reduced output. So they develop exertional chest pain due to subendocardial perfusion. They develop symptoms of presyncope and sometimes syncope. They also develop passive hepatic congestion and ascites. So they present with like abdominal pain and decreased appetite and abdominal distension. The best supportive management at this point when they're not responding to vasodilator therapy is including supplemental oxygen, diuresis, and opiates. Pulmonary rehabilitation is helpful for these patients as it improves exercise capacity and quality of life, especially in the earlier stages. And what the usual cause of death for these patients are usually acute right ventricular failure. And this can be during anesthetic procedures. So we may be consulted whenever there's like a critical surgical procedure that's being proposed for these patients, because there's a very high risk of mortality intraoperatively. If they develop infections or intravascular volume depletion, or for some reason they can't be on their treatments anymore. And just quickly, just a couple of things that you may or may not see, but this is something that I think we have to be aware of. And cystic fibrosis, I think this is something, you know, a lot of us don't know about unless we're in that pediatric realm. I myself am in internal medicine, but what I'm beginning to recognize is that, you know, we are getting better treatments for cystic fibrosis, and there are better opportunities for treatment at a younger age. So a lot of these patients are actually graduating from their pediatric care into adult care. So I think this is something that we do need to be aware of. Like, as we know from medical school, it's a hereditary disorder. It involves a CFTR protein, so it impairs the, you know, the ion transport across the sinuses, the lungs, and the pancreas. And the severity is variable. There is modulator therapy, and it has improved outcomes in childhood. And like I mentioned, these patients actually may transition to adult healthcare providers. There is a decreased life expectancy with some of these patients if they develop things like progressive bronchiectasis, recurrent pulmonary infections, and mortality due to respiratory failure. And these patients often do have a lot of symptom burden, including sinus disease, daily cough, pancreatic insufficiency, which can cause both exocrine and endocrine, so malabsorption issues, and insulin-dependent diabetes and weight loss. The diabetes and the Pseudomonas infections are often linked to the ongoing loss of lung function, and mortality and weight loss are associated with declining FEV1 measurements. And I just want you to keep this in mind because, you know, we may meet this patient as an adult that's been on modulator therapy and that's graduated to an adult. You might meet this patient because they might be encountering graft rejection from their lung transplant. You may also be meeting this patient as a young adult that might be being considered for a lung transplant. So I think it's important to understand some basics with it. And just one last topic, chronic lung allograft dysfunction. It's a very rare condition. You're not going to meet a lot of it. You're going to only meet this with the lung transplant patients. But it is something you do have to be aware about. I mean, for most part, lung transplants are a curative treatment for most conditions like IPF and PAH. The median life expectancy after your lung transplant is about 6.7 years, but they still have a risk of post-transplant morbidity mortality, and this is often due to graft dysfunction. More than 50% recipients develop this at 5 years, and more than 75% of survivors develop this 10 years post-transplant. And it usually presents with the same symptoms for the reason why they went for the lung transplant. They develop dyspnea, cough, progressive respiratory failure, and there's often a role for palliative care for ongoing primary and potential specialist palliative care for these patients. So let's just take a quick breather. I know that was a lot. I just have a quick question before I move on, because I'm going to do a little bit on dyspnea, and I just have some quick questions about what does dyspnea mean to you guys, and are you guys encountering it as in your work so far?
Like shortness of breath.
Okay.
For me, I think it can be like one of the more distressing symptoms patients can have because it creates a lot of anxiety. I think the sensation of not being able to catch your breath can be really life limiting for patients. So yeah, I think it can represent a large burden of suffering for our patients.
Yes.
I think about the word air hunger. Like
Yes.
air hunger, you know, that fear, just the anxiety that's associated with shortness of breath, air hunger.
Yeah. I think these are all relevant. And I think when we, you know, as we're listening to each other and talking about it, I think I hope you both all are recognizing that dyspnea feels differently and is expressed and received differently depending on who you are, what your condition is, and what's going on in the circumstance. And I don't think it's as simple as just shortness of breath. I think there's a lot more to it. And I think, you know, a lot of the leaders in critical care, pulmonary and palliative care are recognizing that, It's actually a constellation and a syndrome that presents in various forms throughout a person's disease trajectory. So, this is a quote that we wrote up an article for the clinics of North America regarding management of respiratory symptoms. And this is something we actually came up with, and I still love it. Breathing is a continuous cycle that we unconsciously perform during a lifetime. The presence of the quality of breath is assessed at birth. Its absence is noted at death. It's so funny, right? We don't even stop to think when we're breathing. We don't even stop to think about it unless like we're getting insanely short of breath. And when it happens to us. And it makes me sort of wonder what's happening to our patients with pulmonary disease and pulmonary symptoms and what that experience is for them, having that continuously. I don't know if can I ask you guys just to participate in something really quickly with me? Is that okay? Okay. Would everyone be open to just having a moment of what breathlessness would feel like right now?
Yes, sure.
Okay. So what I'd love for everyone to do is I'd love everyone to purse their lips, and close off your nose, and just breathe through your mouth. You can use a straw too. And I'm going to check my email and I'll come back to you guys. Okay, no, I won't check my email. I see some of you have aborted. I see some of you are going at it. Miguel, please stop. You were just hitting your chest. But like, what was that like for you just in those few moments of trying to breathe like that?
It felt like when I had asthma when I was younger.
That couldn't have felt good.
No, it's terrible. And that's why I use a straw, because they said with asthma when you're a kid, it's like breathing through a straw.
Yeah. There's there's people that are talking about feels like COVID, chest pressure, anxious. Now imagine like you had that in a brief moment. Imagine our patients, they're living that through varying degrees continuously. What do you think that would feel like? That would be really horrible, right? I mean, that is distress beyond belief. And I think that's something we need to take into account when we're thinking about our patients and exactly about what are we intending to do when we're taking care of them and we're approaching their disease management. So like I mentioned before, patients may not just say shortness of breath. They can say things like they're feeling tired. They're feeling like their chest is tight. They can't take a deep breath. They're not unable to get enough air in. They feel like they're choking. They feel like they're suffocating. Short of breath, breathlessness, unable to catch my breath. So, I think for the purposes of just definitions, dyspnea in general, it's just breathing that's perceived as burdensome. It's not one-dimensional, and it becomes a complex syndrome as the disease progresses. And dyspnea can also mean breathlessness, and that you'll see that a lot in what they're writing in the literature is actually exchanging out dyspnea with breathlessness. Nuance at dyspnea is often acute, right? It's often like an acute bronchitis or an acute cold, and it resolves. But then you have patients that have, with what we are seeing with what we just spoke about, all these patients, they have chronic breathlessness syndrome. So they have a chronic disease, and despite the optimal treatment of their pathology, they're chronically breathless, and it's disabling. And these patients will cycle between this chronic breathlessness and then develop what we call dyspnea crisis, which happens in the later phase of the disease. And this is very horrifying and disabling for patients. If you've ever seen anyone having a dyspnea crisis, it's often sustained and it's severe. And there's horrible breathing even when they're resting. It overwhelms not just the patients, but if you've noticed, it also overwhelms the family member that might be at the bedside or they're taking care of the patient and they don't know what to do. So here's a quick question. Total dyspnea is a concept that describes the synergistic effects of physical, psychological, social, and spiritual factors on a patient's breathlessness experience. Any takers?
True.
True. Good guess, because we're in a dyspnea lecture and we're talking about the multiple domains. So that's an excellent answer. So it is true. You know, and I think we think of total dyspnea a lot like the framework of total pain, right? It's the patient's perception of dyspnea. It's complex. There's multiple synergistic effects on factors on the breathlessness experience. There's the physical, there's the actual physical feeling of dyspnea. Then there's the psychological, the anxiety and the depression that often accompanies the chronic illnesses. The isolation we talked about, the distress of the caregivers and the clinicians caring for the patient often also comes into play. And also there's this existential crisis. People are really recognizing that their body is getting worse. It's progressively shutting down, and that is frightening. And you know, the idea of not knowing if you're going to wake up after you sleep, this is something real for our patients with chronic lung disease. So quick question. In dementia patients, so dementia, I'm totally messing things up for you guys. I'm not even talking about pulmonary disease. The prevalence of dyspnea and breathlessness is as high as A, 1%, B, 7%, C, 12%, or D, greater than 50%. D. Miguel went with D. Jenny, D. Ferdinand, C. All right. So surprise, surprise. Yes, Miguel, you can celebrate. It is greater than 50%. And does anyone have any thoughts about why?
One may be just it's harder to assess, to do that assessment in dementia patients.
Well, yeah, it could be harder, but there are validated scales for respiratory distress. It includes the respiratory distress observation scale. I didn't include it in this lecture, but that is a validated tool by Dr. Campbell from Wayne State. She's done a lot of extensive research on that. And that's actually a validated scale that you can use in patients that are not able to interact. But, you know, what did we talk about before? These patients often have overlapping medical conditions. So these dementia patients often are not having dementia alone in a silo. They often have other medical issues going on. They have aspiration pneumonias that you see at terminal dementia. These patients are often bedbound. They may have concurring strokes. So I think it's important to remember that dyspnea is very prevalent, and it's not just in pulmonary disease. You see it quite frequently in lung cancer, in AIDS, in motor neuron diseases, multiple sclerosis, and stroke, especially our patients that might be bedbound, unable to physically move around. Okay, another question. A 45-year-old man recently immigrated from India with a newly diagnosed metastatic non-small cell cancer. He's admitted for acute hypoxic respiratory failure. He has no previous medical history and has recently started an oncologic directed therapy. He's awake, he's alert, but complains of having heavy breathing. He's febrile on high flow. Those are his vital signs. He has a heart rate of 100, but otherwise everything looks okay. His SAT is 94%. He has crackles on auscultation, no rhonchi. What could be contributing to his dyspnea?
The anxiety associated with a newly diagnosed lung cancer could be one.
Definitely. What else?
The cancer itself, the directed therapy may have affected the soft tissue in the area.
Right, we talked about drug-induced ILDs. That could be going on here. The cancer itself can be causing this, right? The mass, it can be impinging on a bronchus or a smaller airway. You could have a malignant effusion, TB, pulmonary embolism. That's great. Oh my God, you guys are awake. Thank God. So again, this is just a revisitation of what I presented earlier. It's just keeping in mind with dyspnea, there's a lot of overlap, and there's a lot of, it's not just one disease that we're managing in these patients. There's the high flow, definitely. Lupus, maybe, okay. But just keep in mind that there's not just one disease that's often causing these issues in our patients with dyspnea. There's very complicated, and there's a lot of overlap, which what makes dyspnea so challenging to manage. So what contributes to that sensation of dyspnea? So, I think we have to keep in mind there are some direct associations and specific neural mechanisms, right? That work of breathing increases the effort of respiration. This affects muscle afferents, the respiratory muscle afferents that go to the cerebral cortex. There could be increased resistance due to airway obstruction, muscle weakness, increasing exercise effort, the sensation of unsatisfied inspiration or air hunger. This often is related with chemoreceptor activation. Hypercapnia influences the medullary chemoreceptors. Hypoxemia affects the carotid and aortic receptors, and there's often a mismatch that occurs, and this causes this issue of feeling you're not getting enough breath in. The chest tightness as well, this is usually with the bronchoconstriction, and the airway receptors within the bronchi actually trigger pulmonary afferents to the brain. And sometimes there's this dissociation distinct from the work of breathing or the chemoreceptor stimulus that often causes the sensation that you're not getting enough in. And this is just another diagram of showing how complicated, how, just at, just at a physiological level, how we get triggered with breathing and how there's so many different connections and how in different ways, there's a way to address dyspnea. Okay, question. 60-year-old woman with newly diagnosed lung cancer is admitted for pneumonia, acute hypoxic respiratory failure. She has no previous medical history and takes no medications. Oh, I'm sorry. She is awake and alert, but complains of having heavy breathing, no pulmonary embolism, multiple lobar infiltrates without infusions, no bronchial obstruction on imaging, on high flow. Those are the vital signs. Heart rate's 100, otherwise nothing major. Oxygen is 94%. There's bilateral crackles on auscultation, no bronchi, been started on the appropriate antimicrobial therapy. Which of the following would not be appropriate in the acute management of this patient's dyspnea? A, morphine, 2 milligrams IV Q3H PRN shortness of breath. B, handheld fan. C, fentanyl, 12 microgram patch Q72. D, assessment of anxiety. E, discussion of intubation preferences. Got a C. C. Looks like everyone's loving C. And there's a reason. You guys are correct. And we're going to talk a little bit more about that. So I think always the important thing to keep in mind is the evaluation and the assessment, right? And is taking a good history, doing a good physical exam, looking at your results, looking at your imaging, really recognizing, is this something new? Is this something ongoing? Or is this like an acute on chronic process? And where are they on the disease trajectory? I think it's always important whenever we're doing our assessments to include ESAS, because ESAS actually will bring up those other symptoms that might be contributing in to what the perceptions of dyspnea are. And remember, you have to do this ongoing and repeated throughout the disease course. So if you diagnose dyspnea early in the disease trajectory, it's going to be a very different perception 6 months in, 1 year in, depending on where you're at, or even during end of life and the hospitalization as the symptom burden and the symptom issues become more severe. And like I said, you're going to may have to titrate or modify as the disease progresses. And you have to take that total dyspnea perspective about looking at about anxiety and the other aspects besides the physical, not just with the patients, but with the families and the caregivers. And just remember, it's very distressing sometimes to witness dyspnea, not just for the caregivers, but even sometimes for our staff that we collaborate with, the bedside nurses, our colleagues. And management should always be a shared decision-making process. In the setting of new disease or change in chronic illness or hypoxemia, the first course is always trying to do the underlying cause of treatment, specialty consult if it's indicated, depending on where they're at. And if especially patients with serious illness is weighing the risks and benefits of any sort of diagnostic or therapeutic indication and making sure whatever you're doing is concordant with the patient's values and preferences. And it provides what's an acceptable quality of life for the patient. When disease-directed therapy does not impact the sensation of dyspnea and advanced illness, you can offer at that point to focus care on symptomatic relief, where we've gotten past the point of disease-modifying care. So some basic things you can do, and a lot of the nurses you'll see, is just positioning. You'll see sometimes COPD patients will tripod, they'll lean forward, pursed lip breathing, that they're often coached by the respiratory therapists on this. Pleural effusion, sometimes laying patients on the infusion side down to allow expansion of the good lung can help a bit. Fan therapy. Is anyone familiar with fan therapy? No? So fan therapy, or I'm sorry, go ahead. Who's that? Go ahead and share.
I've seen it for patients who have lung transplants. It's just the sense of like they're not getting enough air. So then we'll just get a little fan and just blow on their face to make them feel like they're getting more air.
Yeah, and there's limited direct evidence about that it actually helps. It doesn't hurt. It's inexpensive. It's low risk. And patients may actually benefit from a trial of it. And they've done systematic reviews regarding fan therapy, and they've found that it's something that we should be routinely incorporating into our care. That's become a little challenging now with COVID, about having things flying around in the room. But this is something effectively that can be done at home. And, I often encourage my patients and family members to buy handheld fans and utilize them at home. Pulmonary rehab, we mentioned before, it can be helpful in some patients, especially our COPD patients. And these are usually patients that are more in the community, not so much for our end stage patients that are in the hospital. Breathing training, walking aids, neuroelectrical muscle stimulation, chest wall vibration, some evidence about acupuncture and acupressure. These may help. Non-invasive ventilation is a modality that's sometimes used, and it's frequently used at the end of life. It's highly recommended if we utilize this. Is it the appropriate patient? Is there something achievable in the process of initiating it? What are the intentions? Is this meant to be just a trial, or is this intention to be a bridge to intubation? And making sure that the decisions are patient-centered. What we do know is it does not affect quality of life and does not provide significant dyspnea relief or symptoms in a lot of patients. Once they've lost consciousness or become very sedated, you really shouldn't have them on BiPAP any further. Oxygen therapy is something we routinely use a lot, and we don't even think twice about it. And it's really recommended for patients with resting or exertional hypoxemia. There's an important trial that showed how double-blind RCT examined O2 versus pressurized room air. And they found that with patients with hypoxemia or normoxemia, the dyspnea improved regardless. So what we do know is that pressurized air is helpful in patients with normal oxygen tensions. There was a subset of patients that were normal oxemic at room air, and they found that the COPD patients that had normal oxygen tensions did have some sort of symptomatic improvement with oxygen therapy versus pressurized air, but cancer patients, there was no difference. So the recommendation is with dyspneic non-hypoxemic cancer patients, you should really be assessing them for opiates or fan therapy and should not be really running to oxygen in these types of situations. And then opiates, something we use quite frequently. When disease-directed therapy is limited, or we're finding that whatever disease process we're doing is not affecting the symptoms, what a lot of existing evidence we have in expert societies all support using short-acting oral parenteral opiates for dyspnea and advanced illness, especially for chronic breathlessness and acute dyspnea crisis. Some more recent studies that have come out regarding COPD patients and low-dose long-acting opiates have also shown to be equally safe as well. And these can actually be beneficial early in the disease trajectory, improving quality of life and functional goals. And I think the theory is that it acts on the central opioid receptors. It also affects the peripheral opioid receptors in the respiratory tract and also helps with alleviating anxiety. Again, just a revisiting of the afferents and efferents that we see in perceptions of dyspnea physiologically. We know safety-wise, advanced cancer, COPD, and ILD, there's no concern of induced mortality, respiratory side effects if we've done responsibly and managed appropriately. Chronic dyspnea, long-acting morphine, like I mentioned, is beneficial and safe. Maybe some help with neuromuscular disorders like ALS. CHF, it's not very clear. What's important is talking to your patients, making sure you're having informed decisions, counseling them about what the common side effects can be: constipation, nausea, somnolence, hallucinations. And these are just some starting doses that you can consider depending on the setting that you're in. And they're usually very low doses, especially in patients that are opiate naive. And, it's just to keep in mind, the current opiate epidemic inhibits the use of opiate use because of like the CDC guidelines. Even though the guidelines refer to chronic pain, what's been happening is that they're being applied incorrectly in the palliative and hospice realms. It's still important to risk stratify for substance use disorders, any history of addiction or diversion, and monitor for misuse regardless. And you should follow whatever your state and local guidelines are. Non-opiate medications, there's no evidence that nebulized medications work. Benzodiazepines, you will see some of your attendings using this sometimes, and this might be in situations where you're not able to get good symptom relief with opiates or more closer to the end of life. There's no statistical significant differences found with benzodiazepine type, dose or administration, frequency or treatment duration. It is more sedating than morphine, so you have to really be careful if you do utilize it and what is the intention of using it. Again, it's not the first line. If opiates fail to alleviate symptoms, if there's a more sense of total dyspnea where there might be an anxiety component, you may consider some benzodiazepines, especially at end of life. A lot of our patients have anxiety disorder in COPD, so they've done studies with bispirone, and that's not been shown to be effective at all. Corticosteroids are routinely used in COPD and ILD. I'm not going to go into too much detail with this. There's some rare conditions where patients might request palliative sedation because of distressing end-of-life symptoms, especially dyspnea. It's very rare. I think in my career, I've only seen 2 situations of palliative sedation as a palliative care physician. And this is when all other measures don't improve dyspnea, and it's a last resort option. And this should really be closely done by clinicians and your attendings who are trained and experienced in this. And usually what they utilize is a benzodiazepine infusion. And the jury's still out regarding antidepressants, herbal medications, and cannabinoids. So we're still waiting to see what the effects of these are. But just keep in mind, presence of dyspnea is a risk factor for overall mortality, independent of age, smoking history, or lung function. It's associated with shortened survival in advanced cancer, COPD, ILD, and cardiac disease. So just important things to take away. Advanced lung disease requires palliative care from the time of diagnosis. Basic management is within the scope of primary palliative care, those non-palliative providers, and can be escalated to us when appropriate. Dyspnea and breathlessness is common in serious illness, both cancer and non-malignant conditions. Advanced lung disease exerts significant psychological, social, existential, and spiritual impact and affects their disease experience. You can use pharmacological and non-pharmacological approaches to managing respiratory symptoms. Opiates play an important role in relieving dyspnea and cough in patients with advanced illnesses and should be considered alongside these disease therapies. And we need to have more research focused on palliative management of respiratory symptoms and diseases and about patient-centered outcomes and having better guidelines to be able to guide our colleagues on when to consult us. And that's it. And I know that was a lot.
Big topic.
Does anyone have any questions?
Just a quick comment and a thank you on bringing up the use of morphine for those with chronic dyspnea. I know I had a patient who had end-stage COPD in my family medicine clinic last year, and it was always difficult because she kept going in and out of the hospital. Once we put her on some morphine, longer-acting agents, I started off with oxycodone, PRN, and later extended to morphine. She did a lot better. Still went in and out of the hospital from time to time, but she was a lot less frequent. So it's definitely a useful tool to have in your pocket.
Definitely.